Measurement of renal function is not required before which of the following investigation. So measurement of renal function is needed whenever the dye is given into the vascular system. Vascular system, be it IV or be it IA. CCT, the dye is given IV, cannot be the answer. Angiography, the dye is directly injecting into the vessel, cannot be the answer. In CE-MRI, nowadays we know there is a risk of nephrogenic systemic fibrosis, so the renal function should be measured. In ERCP, the dye is injected into the biliary tract, so there is no risk of renal toxicity, and that is why answer is ERCP. Which of the following isotope is not used for thyroid imaging? A very interesting question. Iodine 131. Iodine 131 normally should not be used because of the beta rays can destroy the gland, but if you want, you can still use it. Iodine 127 cannot be used. Why? Because it's a stable isotope. It is not radioactive, and if it is not radioactive, it cannot be used. Iodine 123 is an ideal isotope, and technetium can also be used because of the affinity for the thyroid gland. So please remember, contrary to your expectation, the answer is iodine 127 here, not 131. A typical clinical pattern question. What is the most likely diagnosis? Oligodendroglioma, abscess, glioblastoma multiforme, and cerebral toxoplasmosis. That is how I will start reading the question if you see a lengthier question. And now I will keep on picking up the important points in the question that I have to pay attention to. 55-year-old presents with seizure, 1 week, a short history. On examination, she has papilledema, there is raised intracranial tension, no focal neurological deficit. Okay. He is febrile and elevated CRP. Undergoes CT with contrast, shows an infiltrating necrotic lesion with a regular peripheral enhancement, no calcification. You are dealing with an abscess. You are dealing with an abscess. Don't jump onto necrotic mass, calcification, and a glioblastoma. Febrile patient, elevated CRP. Examiner is trying to tell you that you are dealing with a case of an infection like an abscess, not a tumor. Okay, so that is how you should read a clinical pattern question to take an advantage. Location of the mass: apicoposterior segment, lingula, anterior segment of the upper lobe, posterior basal segment of the lower. 40-year-old routine chest radiograph as a part of pre-immigration workup. Mass on the left with loss of left heart border. If the left heart border is lost, that means left heart border is silhouetted, and that means the lesion lies in lingula. That means the lesion lies in lingula because the lingula is in anatomical contact with left heart border. A typical example of silhouette sign. Silhouette sign. Now, if you cannot recall it, go back to the videos and see. This is a very important topic, very frequently asked in the exam. Again, a lengthier question. Which vessel should be catheterized to maximize the chance of demonstrating the bleeding point, and what would be the most likely cause? Celiac axis venous adenoma, celiac axis angiodysplasia, superior mesenteric artery venous adenoma, superior mesenteric artery angiodysplasia. I'm thinking one blood vessel and one disease. A 40-year-old man present with bright red rectal bleeding, hypotension, and tachycardia. He is initially resuscitated. Colonoscopist is unable to negotiate the sigmoid colon, and active bleeding is seen from proximal bowel. Endoscopy to the third part of the duodenum is normal. That means these two are out. A technetium RBC scan demonstrates the accumulation across the upper abdomen, interpreted to be the proximal transverse colon. So that means it's a bleeding coming from the proximal transverse colon, and the answer has to be superior mesenteric artery, and the common disease that causes bleeding in the colon is angiodysplasia, and that is the answer. So the whole idea is read the choices, frame something, identify the salient points, and then try to pick up an answer in a clinical question. Very, very useful tip for the exam.